In 2014, a group of Japanese investigators made the first observation that serial brain MRIs fundamentally changed the magnetic properties of the human brain. With repeated exposures to a gadolinium-based intravenous contrast agent, certain neural tissues began to show a change in the signal intensity, a permanent change. The gadolinium metal was irreversibly binding to proteins in various nerve cells, causing who knows what kind of long-term damage. But how can we tell that gadolinium is permanently building up in these neurons? You see, what happens is, on the atomic level, we can see the signal produced by gadolinium on MRI because gadolinium has this unique ability to alter the relaxivity of nearby water molecules. Now, I'll be the first to say that I used to have no idea what that means. If you were a physicist, it would make a lot of sense to read statements like,
gadolinium chelates increase tissue signal intensity by reducing the longitudinal relaxation time, or T1, and transverse relaxation time, T2, which is visualized by enhancement patterns on tissue imaging.
But these words mean almost nothing to me. And if I were to try to explain how relaxation rates change based on the water concentrations in various brain tissues, that may just bore you to death. And it's not the purpose of the show today to explain how MRI works. What we're going to review, instead, is why gadolinium matters for patients undergoing MRI, and what you should know about the administration of this particular contrast agent. What does it mean, for example, that those Japanese researchers found permanent deposits of gadolinium in living human brains? Hey podcast listeners, welcome back to another installment of the Brainwaves Podcast, a show about neurology and medicine and all the fascinating science and history that come along with it. I'm your host, Jim Siegler, and this week on the program, gadolinium. From the basic chemical properties of this rare earth metal to the major complications after exposure. Stay with us. In its purest form, gadolinium is a metal, like zinc or cobalt or copper. Element number 64 on the periodic table, sandwiched between europium and terbium. I wanted to at least acknowledge this because I think it reminds us about the basic chemical properties of this rare earth element, and it has similar properties to these metals, like calcium. I already mentioned that gadolinium is taken up by certain neural structures in the brain, and it will irreversibly deposit into those regions, specifically the globus pallidus and the dentate. But how does this happen? It comes down to the basic principles of chemistry. When you get IV contrast in an MRI, you're not just being injected with a liquid formulation of gadolinium 3+ ions. This is highly toxic, and it can bind to calcium channels, causing neuronal and monocyte damage. So we have to administer gadolinium that has been chemically bound to some other molecule, an anionic or negatively charged chelating ligand. This ligand prevents the gadolinium from dissociating and activating those calcium channels and doing a variety of other harmful things. But dissociation at physiologic pH can occur, and it does occur. And some of the gadolinium-based agents have weaker bonds than others, making them more likely to spontaneously dissociate. Getting back to calcium again, which is an abundant cation in the human body, calcium may actually displace gadolinium from its ligand, liberating those gadolinium cations. At this point, the freely dissociated gadolinium ions are now able to roam the body, sticking to calcium channels, and more importantly, binding other negatively charged molecules in the body, especially proteins and phosphate, which we'll get back to at the end of the show. But we're getting ahead of ourselves. What prompted the development of gadolinium-based contrast? Before the FDA approved the first gadolinium-based compound, gadopentate, in 1988, MRI was not a popular imaging modality. Most centers at the time were comfortable using CT-based neuroimaging, or they used fluorescein angiography or pneumoencephalography. Hospitals were comfortable with these machines. But in the late 1970s, the first evidence suggesting a risk of kidney injury with iodinated contrast had begun to surface. Gadolinium-based agents did not carry that same risk, and there had been sufficient safety data regarding the use of gadolinium even in patients with mild to moderate renal impairment. So it became increasingly attractive to use MRI over CT for this reason, and for a number of other clinical indications, not to mention the higher resolution over CT and that lack of radiation exposure. So gadolinium is convenient because, like iodinated contrast in CT, GAD is absorbed by tissues that are inflamed, tumors, acute demyelination, abscesses, and subacute strokes. Because GAD flows through the circulatory system, it also lights up the blood vessels, allowing for better visualization of the intracranial arteries and the veins in a patient who has stroke or venous sinus thrombosis. Now this is great and all, but what are the risks of gadolinium exposure? That's what we're really here to talk about. On the whole, GAD is relatively safe, it's relatively benign, and patients can receive repeated doses of gadolinium-based contrast throughout their lifetime without any real consequences. But that being said, there are a few exceptions. Most clinicians divide up adverse reactions to gadolinium into two categories, immediate and delayed. In the immediate category, we think of the allergic and non-allergic reactions. As with any exogenous compound, there's always the risk of anaphylaxis. For most cases, this may be better characterized as an anaphylactoid reaction, since prior exposure is not necessary to induce the same immunological response. Simply by exposing a patient to gadolinium, mast cell degranulation and complement activation can occur, and patients can feel warm or itchy. They even can develop a more severe response, including hypotension or shock. Milder cases of anaphylactoid responses are really quite common, maybe one mild reaction for every 1,000 exposures, whereas major immunological responses are very rare, something like one case for every 20,000 exposures. And then there's death, one for every 3 million exposures. As of 2017, there have been over 200 million known MRIs where gadolinium-based agents were used, with only 614 patients having suffered severe reactions, and only 54 cases of death or permanent disability. Because the risks of these adverse reactions are so rare, and because the various gadolinium-based compounds are so similar, there's not really any greater risk with one agent versus another. Nor does the risk of an allergic response to gadolinium mean that you're necessarily going to be allergic to iodinated contrast that's used in CT imaging. And I'll say this again, in case you missed it. An allergy to gadolinium does not mean an allergy to iodinated contrast, and an allergy to iodine does not mean an allergy to gadolinium. But there is one caveat to this. In patients who have a hypersensitivity to iodine, or a hypersensitivity to GAD, these patients may have an underlying predisposition to any kind of hypersensitivity. So if they reacted to gadolinium in the past, they may be at a greater risk of reacting to iodine, but they also may be at a greater risk of reacting to Tylenol, or to penicillin, or strawberries, or anything else for that matter. And if a patient does report a prior allergy to gadolinium, and you need that MRI, say a patient has MS and you're looking for new lesions, then experts recommend pre-treatment with corticosteroids, although there are no trial data to support dosing or efficacy here. I've also read that some centers use an alternative gadolinium-based agent, since it's thought that there's almost zero cross-reactivity between the FDA-approved compounds. The allergy is more towards the ligand rather than to the gadolinium. In addition to anaphylaxis, which again is more of an immune response, there are immediate non-immune responses which are typically physiologic. The administration of a gadolinium-based agent may transiently alter the osmolality of the blood, or the agent may bind to non-immunological receptors in the body, causing them to activate, especially those calcium channels. Most commonly, patients who are aware of this will report a sensation of rush or anxiety. They can become nauseated or dizzy. And many of these milder reactions are difficult to distinguish from a placebo response, but bear in mind, some people may have a legitimate biological reaction to a contrast agent. Of the more severe non-immunologic immediate responses, patients may experience a severe vasovagal response, or hypertensive urgency, or worse, they could have seizures or an arrhythmia.
All right, I'm clear. You guys clear? Everyone's clear? I'm not seeing answers.
So those were all the immediate responses to GAD. Of the delayed responses, there's the slow deposition of gadolinium throughout various tissues over time, and then there's NSF, nephrogenic systemic fibrosis. But let's start with the gadolinium deposition. In 2014, a paper came out showing that T1 hyperintensity of the dentate and globus pallidus directly correlated with the number of prior gadolinium exposures, that Japanese study that we first referenced. It's not surprising, I guess, given what we know about renal clearance of this compound. Maybe it's just that some patients can't clear the GAD as well. The thing is, that high signal abnormality persisted even after controlling for patients' creatinine clearance. It didn't matter if the patient's renal function was poor, gadolinium still stuck to the brain. Cadaver studies have also confirmed this finding. But what does it mean? Are these gadolinium protein complexes in the central nervous system disrupting the normal neurological function? Should we expect more Parkinsonism or dysmetria in patients who get more and more MRIs? The truth is, we don't really know yet. And it's kind of a difficult question to answer, really. Like we discussed with Ali Hamadani on the show regarding bias recently, there's a lot of confounding here. In patients for whom you get repeat MRIs with contrast, there may be a chance that those patients have more weakness, or dysarthria, or ataxia, or any other neurologic symptom for that matter, when compared to patients who don't get repeat MRIs with contrast. But that may have a lot more to do with why those patients needed more and more MRIs with gadolinium to begin with. Do they have more brain lesions, or have MS or tumors that require surveillance? The underlying pathology in these patients may account for their neurologic sequelae, not the gadolinium. For now, I'll just say that there have been no definitive cases reported where gadolinium deposition in the brain has caused any long-term neurologic complication. And then there's NSF, which is previously known as nephrogenic fibrosing dermopathy. This is a horrifying complication that every medical professional who orders MRIs has heard of. But what is NSF? Well, let's go back to 1988, when the FDA approved the use of IV gadopentate in MRIs, with virtually no restrictions. This was corrected in 2006, as evidence became available that some patients who were given gadolinium began to develop subacute but irreversible skin disfiguration. They developed joint contractures and other forms of soft tissue injury. In that year, 2006, the FDA issued a safety statement cautioning the use of gadolinium in patients who were on hemodialysis or who had a creatinine clearance of less than 15. Eventually, the FDA would declare the various gadolinium compounds to be contraindicated in patients whose GFRs were less than 30. But how does that happen? Well, I can tell you that it's not just because GAD deposits in the skin and soft tissues. Patients who have intact renal function also have gadolinium deposits in their skin, and they never seem to be affected. So far, there are no cases of NSF in patients whose creatinine clearance is more than 60. So there's more to it than just the simple deposition of gadolinium in the skin and soft tissues. But we don't really know. What we know is that in patients whose renal impairment results in a creatinine clearance of less than 30, the gadolinium complexes can linger in the peripheral blood for a long time. Long enough such that the phosphate anions that circulate in the blood can compete with the chemical gadolinium ligand and then ultimately displace it. Then the phosphate binds to the gadolinium, and newly formed, these gadolinium phosphate complexes will precipitate in almost every tissue, attracting macrophages and other inflammatory cells. These cells then secrete TGF-beta, which attract fibroblasts, and the fibroblasts will ultimately produce this fibrotic response that we see with NSF. Now, this isn't a rapid process. It develops slowly over time, most often over about 6 months once gadolinium's been given, and almost never has it occurred more than 2 years later. It is an extremely rare complication, a 1 in 200,000 chance, and even in patients whose creatinine clearance is poor, there's still only a few % chance that it would actually happen. If you have to give gadolinium, experts usually recommend immediate hemodialysis following the contrast exposure. Clinically, when patients have NSF, the patients typically present with skin thickening of the extremities, sometimes involving the trunk. Joint involvement is common, and it's a major cause of morbidity as the contractures develop. In rare circumstances, patients can even develop fibrotic changes of other organs, like the lungs, the liver, and the heart. And this is what prompted the change in nomenclature from nephrogenic fibrosing dermopathy to nephrogenic systemic fibrosis. Clinically, what does this mean? If you're the neurologist and you need to get an MRI, then the American College of Radiology and the FDA agree that those patients should be taken back for another hemodialysis session after the MRI is performed. In addition to its deposition in the skin and certain regions of the central nervous system, as we've discussed, gadolinium also deposits in the bone and the liver over time. Newer agents, like gadoterate and meglumine, also known as Dotarim, appear to have stronger bonds between the gadolinium and its chelating agent, and as you'd expect, these agents are associated with a lower risk of tissue deposition. So as we continue to build our knowledge about these chemical properties, so too may we be able to avoid these inadvertent consequences. Next, let's discuss pregnancy. It's surprisingly common to need gadolinium-based MRIs in pregnant or breastfeeding women, especially given the risk of radiation exposure using CT modalities. You see a pregnant woman with a new severe headache, it's going to be hard not to get that MRI and MRV. If you see a pregnant woman who has MS who's discontinued her immunotherapies because she's now pregnant, and now she has new focal weakness, you may want to confirm that it's her MS and treat with corticosteroids. Luckily, there is a good deal of evidence that gadolinium-based agents are safe in these circumstances. While a contrast agent can cross the placenta, and it's even found in the bladder of the fetus within 11 minutes of administration, there are limited data to suggest that it's toxic to the growing baby. Most of the data we have on this are derived from retrospective observational cohorts, and there's only one large-scale study of 1.4 million Canadian deliveries that suggested a slightly increased risk of stillbirth or neonatal death when moms were given gadolinium. But it makes you wonder why those mothers needed gadolinium to begin with, kind of back to that confounding point, and if those maternal factors were driving the poor outcome and not the gadolinium. That said, the American Congress of Obstetricians and Gynecologists say that gadolinium can be used when it improves the diagnostic accuracy of the MRI, but use should be limited. The ACOG also says that GAD use should not deter any breastfeeding, since the concentration in breast milk is 10,000 times lower than what a fetus is exposed to if the pregnant woman were to receive IV contrast for an MRI. Moving forward, what is it that we have to look forward to? Well, I think we can all agree that we're not getting rid of any gadolinium-based compounds when it comes to our MRIs. 30 million MRIs are performed every year using gadolinium. They're extremely useful adjuncts to our neuroimaging modalities, and they are integral in making diagnoses. But that doesn't mean that gadolinium is perfectly benign. In addition to the risks of GAD exposure among patients with renal insufficiency, there are potential risks in patients with normal kidney function. There are potential risks in pregnant women, and women who are breastfeeding. And there are even risks in patients who don't get MRIs at all. This next part's kind of interesting. So since the implementation of gadolinium in the 1980s, studies have shown that there are increasing levels of gadolinium in drinking water of major cities. As we use it, our urine dumps almost all of it into the sewer systems, later to re-enter the potable water supply in our water treatment plants. And right now, we simply don't have the technology to decontaminate the gadolinium from these sources. As we develop newer gadolinium ligands, like Dotarim, hopefully we can mitigate these risks. I think one of the biggest concerns out of all this is the risk of those anaphylactoid reactions to gadolinium and the risk of NSF, both of which are highly serious concerns. The immediate immune responses to gadolinium are extremely rare, as we discussed, and you have to deal with them for any type of pharmacologic exposure. But the risk of long-term NSF in patients who have renal insufficiency should be avoided whenever possible. It is a relatively low risk in the grand scheme of things, but the consequences are irreversible, and they can dramatically shorten one's life expectancy. I think that if you know these risks and you discuss them with your patient, we can all make more informed decisions regarding the use of contrast in magnetic resonance imaging. That's all we have on the program this week. I think the show today was fairly comprehensive, although of course we can't cover everything. We didn't get into the details about the reactive oxygen species formation or smooth muscle inhibition with gadolinium exposure. We didn't talk about this controversial entity of a gadolinium deposition disease, which is also very interesting, and it's something you should read about on your own time. As always, you can take a look at the literature yourself and see what we've posted in the show notes. And if you want to continue your medical education using brainwaves, take a listen to something else from the archives, or follow us on Twitter at Brainwaves Audio. The Brainwaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. Jim Ziegler, senior producer. Music for this week's program was courtesy of Little Glass Men, Loyalty Freak Music, and Kevin MacLeod. Sound effects by Mike Koenig and Daniel Simeone. I'm Jim Ziegler. Thanks for listening.